a lot for the presentation. I think we continue with some polling before we start with the discussion, right?
Absolutely. So I'm going to start sharing the screen with the polling questions. Okay. Okay, for those who are new and joined just now our session, you will have, okay. On your screen, there is the question for the polling for this session. And if you are new and joining just now, just click on the link on the right of the live session. The question is, P2Y12 inhibitors. Which antiplatelet drug is most commonly used in your hospital? Is it ticagrelor, clopidogrel, prasugrel, cangrelor, or no use of P2Y12 inhibitors? More or less from the presentation of Dr. Lomakin, we saw in Russia that clopidogrel was the most commonly used, and this is what we expect also worldwide, but also it would be good to see the percentage of usage of other drugs in your hospitals. So as expected, clopidogrel is still the top one. We see it is almost 80%. And ticagrelor is the next one, about 16, followed by prasugrel for 4%. It'd be interesting also to understand why more ticagrelor than prasugrel as an alternative, but maybe that's a question for the discussion round. And okay, yeah, more or less this is looks like the stable response. So I'm going to lock the vote right now with these results around 80, 14, and 4. Clopidogrel, ticagrelor, and prasugrel. Okay. Moving on to the next question is something that that is asked also to us when we are visiting potential clinicians who would like to use individualized antiplatelet therapy monitoring. So the question is, do you have a protocol for individualized antiplatelet therapy monitoring in your hospital? And the responses are, you can say either yes, no, or you can also say no, but may bring an added value. Wow. I see the poll is changing very rapidly here. Okay. Yeah, so, and it's also surprising for us to see that there is a protocol for individualized antiplatelet therapy monitoring, and interesting, but that is becoming smaller and smaller. And now we are more towards no, but we bring added value. And no. Okay. Okay, just 10 more seconds and then we can lock the responses. Okay. So I'm taking a note that no, but may bring added value is the topmost voted, followed by no around 34%, and then yes 21%. Super interesting to hear from the comments of, I hope those who said yes will also comment in the chat box, hopefully. And then I log this vote and move to the last question for our polling. Sorry, no, we had only 2 questions. Okay, I stopped sharing my screen. And first of all, thank you, Dr. Lomakin. Very, very, very interesting presentation. And I'm so glad we have also Dr. Daniel here, who you have shown his work also. So Over to you, Klaus, for starting the discussion.
Yeah, maybe we can just start with one of the polling questions. And we have seen, yes, there's still clopidogrel, the most used ADP receptor antagonist, but then number 2 was ticagrelor. So in which indications you would move the question to both panelists to ticagrelor? Or so what would be the main indication for you to switch the patient on ticagrelor?
To switch the patient to ticagrelor
Yes.
or clopidogrel.
Yeah, what would be the indication to put the patient on ticagrelor?
So let's say that the mainstream therapy for example, for ACS patients, if you open the current guidelines, it's ticagrelor and prasugrel. It's if you read just the statement, but in routine practice, as we just saw, the same situation in Russia and in Europe is that the majority of patients still receive clopidogrel. Why? Because most of our patients are elderly patients, they're comorbid patients, they have indications for different other anti-thrombotic agents. Of course, we need to remember that some patients, it's the patients after elective stenting, and if we open the current guidelines, clopidogrel is still recommended for elective stenting. And as I tried to show you in our scheme, is that today we developed enough data for de-escalation therapy. So to manage bleeding risks when we deal with ticagrelor and prasugrel, but we still have very conflicting data, and we still have not enough data. Maybe Daniel could say something more, but we have not enough data to support the escalation strategy. But we really need to do something with the patients who receive clopidogrel. And as we just colorfully see, that the majority of patients still receive clopidogrel.
So thank you for the question. If I may start with an overview of why we still have clopidogrel in the majority of the patients. I think if you look back to the past 20 years, pharmacodynamic studies in the early years of the 21st century discovered that a lot of patients have inadequate response to clopidogrel and high platelet reactivity. And after these results, there were studies claiming that in high-risk patients, such as in ACS, the new and potent P2Y12 inhibitors are better than clopidogrel. So people started to think about clopidogrel is an old and bad agent, and the new P2Y12 inhibitors are the good and better new modern agents. And we wanted to give these new drugs for everyone without any individualization. But in the current guidelines, we see that this strategy failed. And the reason of failure is that clopidogrel is not bad in general, but it's heterogeneous, which means that in a proportion of patients, it acts good. Even in a small proportion of patients, it's even very strong platelet inhibitor, but in approximately 30 to 40%, it cannot generate enough active metabolites. So clopidogrel is not a good or bad agent, it's a heterogeneous agent, and there are some indications where it will work, and there are others where it will fail. So as Nikita highlighted, there are many patients who have high bleeding risk. And in such indications, I think it turned out that clopidogrel is still the best alternative. Elderly patients, patients with atrial fibrillation, mechanical valves, and low-risk interventions. However, in such patients who have very high risk for thrombotic agents, such as STEMI patients, very complex interventions, and in those patients who have high platelet reactivity, we need stronger platelet inhibition. And I think we need to combine all these data together to make a good decision. And this is now incorporated in the recent guidelines, which in 2020 non-ST elevation guidelines is a call for individualization. It doesn't say that exactly what is the receipt what is the best way to do it, but I think it's a clear call for individualization to balance the risk of bleeding and thrombosis. And I always say the platelet function testing is not a guide for all, it is one piece of the puzzle. So I think that clopidogrel is still a viable option in many patients, but I wouldn't say that the new P2Y12 inhibitors are useless, because in many high-risk scenarios, we should use them as a first-line therapy because they are really proven to reduce thrombotic agents. So overall, I respect the high rates of clopidogrel seen in these countries, and also the cost issues are still important things in consideration, also in Central Eastern Europe, until we have the generic prasugrel and ticagrelor available.
Yeah, thanks a lot. I think also in one of your first slides, Nika, you showed that there is an increasing number of more and more potent drugs, of course, available on the market. There's even also a more or less new group of drugs on the market, like PAR1 inhibitors, like Voraxapar. So what is the position of these new drugs within the portfolio of platelet inhibitors? Is that for very specific indications, or is it used at all without any testing? But then we have also the problem that not all platelet function analyzers can look at the thrombin pathway. So how we can, what is the role of these new drugs maybe in the portfolio?
Yeah, if I can answer first.
Yeah.
I think thrombin pathway is very important. We know that this is an interaction between coagulation and platelets, and this is a very, very strong and independent platelet activator, thrombin. However, how to block the thrombin pathway is a difficult story, because PAR1 inhibition by Vorapaxar sounds good, but didn't work really well because of the agent's extremely long half-life. So Vorapaxar itself, I think, is not in clinical use, because adding an agent, a PAR1 inhibitor, on top of aspirin and clopidogrel with such an extremely long half-life increases bleeding and fatal bleeding events in a way that is not acceptable. However, what we see in other areas, such as a combination of low dose of anticoagulation, such as rivaroxaban, which itself is an inhibitor, indirect inhibitor of thrombin generation and thereby thrombin-induced platelet activation, is a proof of concept to me that this thrombin pathway should be blocked in the future. But I think we need better direct PAR1 inhibitors with shorter half-life to have these agents in practice.
Anything from you to add, Nikita?
I just want to absolutely agree with Daniel. Fortunately or unfortunately, we have no place for Vorapaxar in the current guidelines due to the reasons just Daniel just stated. Yes, we have new data today in the guidelines of using first of all of a prolonged dual antiplatelet therapy, the possibility of using triple antithrombotic therapy with clopidogrel, aspirin, and low dose of rivaroxaban, and also to use dual antithrombotic therapy with aspirin and a low dose rivaroxaban for a long period of time. And this is one of the ways we could act, and we could influence to the thrombin. Another question is, do we need to test the efficacy and safety of rivaroxaban? This is another very hot topic.
Yeah, that also brings me to the question you mentioned. On the one hand, we talk about half-life time, and that, of course, if the half-life time is very long, okay, you have a continuous effect, but also when you stop something, maybe the effect also is still there for a long time. And since I'm coming from anesthesiology and intensive care, I was always thinking, when we talk about, for example, patient on cardiopulmonary bypass, yes, we give heparin, but we don't do anything to protect the platelets because heparin is not really protecting them. Do you think in the future there's a role for very short-acting antiplatelet drugs, which we can use even in big cardiac procedures to protect the platelets? We do something similar, I think, in HIT when we add prostacyclin or GP2B3 receptor antagonists. But I think these drugs are not really appropriate actually for a routine use in cardiac surgery or in patient on ECMO, where we want to prevent that the platelets are activated and consumed. Maybe an idea?
We have low-acting cangrelor today, so we could inject it during the coronary intervention procedure. So I think there is some place for the low-acting antiplatelet agents for the acute scenarios, for the patients with ACS when we need to act the platelets urgently, and when the patients were not preloaded, so the patient didn't have the loading dose of P2Y12 inhibitors. Yes, I think there is some place for low-acting antiplatelet agents, yes.
Just one remark, it was very tempting that ticagrelor as a reversible antiplatelet agent may have an antidote, because there is a publication that when you give an antibody and it traps ticagrelor active metabolites in the plasma, it can even bring off the active metabolite and the ticagrelor agents from the platelets, restoring platelet function. So we may have one oral agent with an immediate antidote, and we don't know really how this may affect bleeding rates during acute cardiac surgery or acute non-cardiac surgery in patients who are treated with P2Y12 inhibitors. However, with prasugrel and with clopidogrel, as you said, they are irreversible agents, so you need to manage these patients by knowing that the platelets are completely blocked until their lifespan. In our institution, although we have cangrelor in the guidelines, due to availability and price, we still don't have too much access to use this short-acting intravenous agent. But I would like to see some platelet function results also for the dosing, because I think the optimal dose would depend on the indication. So a different dose is needed for PCI to prevent stent thrombosis, and a different dose would needed during cardiac surgery to prevent any coronary event without bleeding.
Yeah, it was also mentioned, I think, that of course we see the antiplatelet effect to prevent ischemic events, but there might be also a quite important anti-inflammatory effect of antiplatelet drugs, and maybe there's even some interaction, since also thrombin is also of course an activator of coagulation, but also plays an important role in inflammation again, and also maybe the combination with IV direct thrombin inhibitors also in inflammatory diseases, if it's COVID-19 or something else, where we move some patients from heparin anticoagulation to alternative anticoagulation, that we might get some additional anti-inflammatory effects, or the combination. If a heparin, low molecular heparin is not effective, might there be a role also to treat the patient in addition with antiplatelet drugs? Of course, it's a little bit speculative, but
I think that this is very, very interesting and very important issue in terms of COVID-19. We have one ongoing trial today in our hospital using different antiplatelet agents in patients with COVID infection. So the hypothesis is that that the platelets play very active role in inflammation and in the process of destroying the virus, because platelets, they like macrophages, so they try to take the virus and to destroy it. So we have some preliminary results of our study, which shows that if you start to use very potent antiplatelet agents at the first stages of a disease, in the stage of the virus aggression, so you will get not very good results, because you block the platelets, which play some role in virus destroying. So this is just for discussion. We don't publish it yet, but this is what we have today.
You know, just one comment. I really like these very nice figures of Nikita about the interaction of platelets and leukocytes, and these are really extraordinary nice figures to really see what you don't see really with your eyes. Just as a very simple tool, in our previous studies, we saw the link of the leukocyte count and high platelet reactivity. So the interaction was not visualized as in your elegant study, but just by laboratory markers and statistical markers established. So I think there's a strong link between platelets, platelet function, platelet reactivity, and leukocyte count and leukocyte activation, which is really a marker of a disease, a systemic disease. In some parts, like in ACS, it should be suppressed to prevent thrombotic agents. However, if you have an inflammatory disease, as Nikita said, this may be a real defense system of your immune body. So platelets' role are really heterogeneous, and we need to learn more in such unexpected diseases to find out.
Yeah, thanks. I have one other question. You were also talking about bioavailability. And of course, maybe this is not the big issue in the outpatient, but since I'm dealing quite a lot with ICU patients, we saw in several patients, if they were on ECMO or just, for example, a pediatric patient after a liver transplant, where the risk of hepatic arterial thrombosis in the pediatric population is much higher than in the adult population, that we saw, we treat them with oral aspirin, and there was no effect at all, even if you give her a 5 kilo baby or 500 milligrams of aspirin, nothing. But if we move to IV aspirin, it works immediately. So this seems to be definitely a problem of bioavailability. But if we just wait that we get a hepatic arterial thrombosis, this is more or less a fatal event after a liver transplantation. So does that mean in critical ill patient, we have to look more on bioavailability of antiplatelet drugs compared to your outpatients or patients not critical ill?
So I don't think that that we, for example, need to test the patient in critical case, in patient in emergency department for the bioavailability of aspirin, for example. We just need to take into the account that some drugs, some forms of the drugs have a low bioavailability, and some has good bioavailability. And according to these studies, according to this information, we need to use appropriate drugs in critical case.
You know, I think this is a very difficult dilemma, because I'm mostly dealing with patients with cardiac arrest and compromised circulation. So I see some patients who have successfully reanimated after out-of-hospital cardiac arrest, and they are cooled, so they are therapeutic hyperthermia, they have compromised circulation, so oral formulations of agents just doesn't work. And not only aspirin doesn't work, also the P2Y12 inhibitors, which require a bioactivation, doesn't work. So there have been nice studies to show that during therapeutic hypothermia, the so-called high responsiveness on clopidogrel is a lot higher than in other diseases. And, sometimes we give opioids to prevent shivering, which also decreases the bioavailability. So in such patients who have compromised circulation, have opioids that also blocks gastric prokinetic effects, I think we need to move to the potent P2Y12 inhibitors, mostly ticagrelor, which doesn't require bioactivation through the liver, by even crushed tablets. And in addition to this, IV aspirin to prevent stent thrombosis if patients are coming with an ACS. Liver, I don't have any experience with the liver transplants and trauma patients, but I think in those complicated patients with ACS and out of hospital cardiac arrest, we prefer to give IV aspirin and crushed tablets of ticagrelor or cangrelor to prevent thrombosis.
Okay. Are there any
I
questions?
just want to.
Oh, yeah.
I just want to add, Daniel, that in some cases after the resuscitation in intubated patients, we use it is off-label usage of 2B3A inhibitors to manage platelet activity. Sometimes we do so.
Yeah, I think this is an alternative if you don't have cangrelor and you require an IV agent. I know that GP2B3A inhibitors are also looking old agents without real indication, but I think with the new guidelines of restricting pretreatment of P2Y12 inhibitors in non-STEMI patients, we're still using IV agents more and more in the cath lab.
I think it's very interesting to look at the pathophysiology and also the interaction, as you mentioned, between platelets, leukocytes, maybe even endothelial cells, which are even more difficult maybe to manage or to see, because I think there are also increasing data just coming from trauma and sepsis that in severe trauma or in bacterial sepsis, there's a very early drop in platelet functionality, in particular of the ADP and thrombin pathway. And in trauma, the group from Denver, from Ernest and Hunter, who showed that this seems to be not mainly a problem of the platelet itself. There seemed to be a liberation of endogenous antiplatelet drugs, if that's cytokines or something else, because transusing platelets, they get inhibited again. Or if you even take the plasma from these trauma patients and add new platelets, they get inhibited again. So I think there are a lot of things also to learn about these interactions in other situations like trauma or sepsis.
Yeah, I couldn't agree more. We see very similar changes in patients after CABG surgery. So immediately after surgery, you have blocked pathways of the arachidonic assays and then increased reactivity later on. So there is some fluctuations in open bypass graft surgery operations as well, which we were seeing in the past years. We don't really know how to deal with it. Is it a normal shift and just look for any complications, or we need to react on that? But as you said, platelet transfusion is not really for any use in such cases.
Mm-hmm. Okay, Poonam, did you see some questions from the floor? Yeah.
Yes, there are questions. So regarding the poll, we saw that there was a big majority that said no, but a protocol may add value. So could we please discuss this part also? In Dr. Lomakin's presentation, you had a value of 230 for a discussion of whether ticagrelor or clopidogrel. So how, if a new user, a new clinician, a cardiologist wants to start individualized platelet therapy, what would be the ideal way to get into individualized platelet therapy? What kind of protocols and cutoffs are required to be confident with the treatment? So this question goes to both of you. Probably you can explain in your practice? How would you guide the other new clinicians using individualized antiplatelet therapy?
So I can start. Of course, if we don't have information in the guidelines, of course, it becomes very complicated question, because we have a lot of groups, a lot of research institutions, and each institution could have its own protocol. I could tell you about what we do in our hospital. So we use two different systems. We use LT with 20 micromoles of ADP as an inductor, and we use Verify now as say. So we use Verify in acute condition. What I need to tell you is that we test all the patients who are admitted to our hospital with with the ACS and who receive P2Y12 inhibitors. We also test the patients after peripheral interventions. I mean, carotid stentings and lower limb stenting, and we test the patients who receive clopidogrel, and we test the patients who receive prasugrel. We do not deal with patients on ticagrelor and on 2B3A inhibitors, because the percentage of the patients of non-responders on ticagrelor or 2B3 inhibitors is extremely low. So we do it on the first 24 hours after the first drug administration, and then we continue the clopidogrel therapy if the patient has adequate response, and if the patient is in a HTPR group, then we switch him to ticagrelor or prasugrel if it's a coronary condition, and to only ticagrelor group, despite the fact that there is no indication for ticagrelor in carotid stenting and in lower limb stenting. So this is, if in brief, this is what we do in our hospital today. So yes, we have some conflict with current guidelines, because what we do it off-label. But I think that if we want to do something more for our patient, we need to personalize therapy, and we need to move a little bit forward.
I think the situation in Hungary is quite similar. It means that we cannot give with full reimbursement the new P2Y12 inhibitors for everyone. However, if I give a small recommendation as a user, how to start as a clinician, I think there are some cases when you have no doubts in your clinical practice. The patient has a perfect intervention, they have low risk for bleeding, they have high risk for thrombosis, such as diabetics, such as STEMI patients. Try to give the new P2Y12 inhibitors according to guidelines. And there are the very high-risk bleeding patients, elderly, AFib patients, anticoagulated. Then we use clopidogrel as a P2Y12 inhibitors. But there is a gray zone. There are some patients where you have doubts. Also high bleeding and high thrombotic risk, or imperfect intervention, let's say very calcified lesion with inappropriate result after a PCI in an elective case. And then you have doubts how to choose. And then you have a marker, an additional marker, a biomarker, which is platelet function. And with this marker, using a verified assay, a validated assay, which is verified now, I think, and multiplate, these two assays are validated. They have cutoffs that you can follow to choose the best P2Y12 inhibitors for your patient. So always try to add the platelet function value to the clinical picture of the patient. And if you have clinical doubts about the patient, I think you can start using the kits to make better decisions. And yes, we have some places where we are using this platelet function device for research purposes when you have routine testing cases. But I think as a starter to give more individualization, start using these devices when you have clinical doubts about your best decision.
I want to to comment Daniel and ask him a question. When he visited us a couple of years ago, he showed the Hungarian model of platelet function testing after stent implantation, and as I know, it was one of the first national models, and so they started from generic clopidogrel, if I'm not mistaken, and they tested all the patients, and it was covered by the insurance companies in Hungary. So does it still exist today, Daniel, in Hungary?
Yeah, in brief, it worked so well that they didn't change too much. So although we expected that it will change based on the guidelines changes, fundamentally, we still have the recommendations to use platelet function testing to choose between the new P2Y12 inhibitors or prasugrel. And in fact, as you mentioned, we also have proven that those centers who use the platelet function testing devices more had lower mortality rates than those who didn't use it. So in fact, it was a proof of concept. However, we still think that we don't want to violate the guidelines, so that in high-risk patients such as diabetes and in those who have chronic kidney disease and those who are after stent thrombosis, these are three indications where you can give the potent P2Y12 inhibitors first line. But if you don't have these clinical indications, it's still the platelet function testing to decide between these two types of agents.
Thank you for the very elaborate answers. You want to add something, Dr. Lomakin? It seemed like you wanted to say something in response.
No, I just want to say that it was a really nice discussion.
Yeah, it seems like because having the cost savings reflected on the, let's say, the health institutions and the public health will have a big effect on the value of doing this individualized medicine, because at the end the benefits will go depending on the health sector, the way it is working in that country, to have more savings, probably to invest in other arenas through this individualized platelet testing. One comment about that, about the genotyping that you mentioned in the beginning. Precision medicine with genotyping is also becoming a new way of doing individualized platelet therapy monitoring with the Taylor PCI trial. No, they did a study where they did not have a significant p-value, was 0.055, but there was a reduction in complications of 34%. What would be your comments on that, and how would you put this together or keep them separate?
I could tell you my point of view, and it is that, of course, pharmacogenetic monitoring of antiplatelet therapy play some role, but not the dominant role, because the pharmacogenetic, it is the only one pathway of the scope of the problems of for example, clopidogrel resistance. And when we measure the biomarker and platelet function testing, it's the biomarker which stands a little bit higher than the pharmacogenetic measurement. So we, from my point of view, we receive more information about what really happening with the platelets, because yes, of course, pharmacogenetic testing could show us does patient have or don't have polymorphic markers. But it doesn't mean that in 100% of cases he will be resistant or non-resistant to clopidogrel therapy. I think it's better to have information from biomarker than from pharmacogenetic testing.
I think I agree with Nikita that the platelet function results are giving more information about the whole problem, the scope of problem, which increases platelet reactivity. However, there are some advantages of both assays. So